Hi and welcome to the Year 5 MedSoc series. And today we will be exploring urology and gum/HIV. So we're going to cover a lot today, but these are all very high yield important topics. And we'll start with urology. Now, urology will cover many important sections, starting from the kidney, going to the bladder, including the prostate as well. So for the purposes of time in regards to the SBA, I'll just give around 20 seconds to answer it and I'll just move ahead. We're not going to do any polls or anything like that. So let's start with the kidney and renal tract, and we're going to start with an SBA. So a 70-year-old man undergoing chemotherapy develops renal colic and hematuria, but no stones are seen on imaging. So what do you think is the most likely type of renal stone in this scenario?
I don't know, but maybe uric acid.
Perfect, well done. So the answer is indeed uric acid. And there was two ways you really could have got this. So there was the chemotherapy aspect, which can result in increased cell death and increasing the uric acid. But there's a second, more low-key thing that might have given it away, and that was the fact that there was no stones seen on imaging. So uric acid stones are actually radiolucent, so they wouldn't be able to be seen, whereas the other ones described here are radio-opaque, so they should be visible. So before we go into the etiology, investigations and management, it'll be useful to talk a bit about the composition of renal tract calculi. So generally, these form because of dehydration resulting in oversaturation of urine. The most common are calcium stones. Of these, the calcium oxalate are the most common, and slightly less than that is calcium phosphate, which is around 10%, I believe. Now, risk factors for calcium stones include things that might result in more calcium in the urine. So there are familial conditions that cause hypercalciuria, but also general increase in calcium, such as hyperparathyroidism, can also result in an increased risk for calcium stones. Now, exam SBAs don't typically follow the most common pattern. So they don't typically test you for calcium stones as much as they should, and they focus on stones that have specific characteristics. And most of all, this is struvite stones. So these magnesium ammonium phosphate stones are the most common cause of staghorn calculi. And if you look on this image on the right, these are ones that fill the renal pelvis completely. And the important pathogens that are associated with staghorn calculi include ones that produce ureates. So that includes urea plasma and proteus. So you might find in question stems that this will be the giveaway that it's a struvite stone. We already discussed urate stones, so ones that contribute to high purine in the blood. So chemotherapy can be something, whatever there's a lot of tissue breakdown, so that can also include hematological disorders. So the more urate, the more chance they'll crystallize in the urine. And whereas all these are radio-opaque, urate stones are radiolucent. Less important are cystine stones, and these are related to homocystinuria, which is an inherited condition. So we've discussed some risk factors already, including dehydration, calcium causes. An important one here is renal tubular acidosis. Well, I say important, but it's an SBA fact that might be useful. So type 1 and 3 are related to calcium phosphate stones. For the urate stones, that other risk factors include gout and an ileostomy. And sometimes in question stems, they might talk about medications and a renal stone. So if you notice the patient's on a loop diuretic, and loop diuretics normally cause hypocalcemia, so therefore you can extrapolate from that the loop diuretics will increase the calcium in the urine, and they can promote calcium stones. So whereas loop diuretics cause more calcium in the urine, thiazide diuretics actually reduce the amount of calcium in the urine because they increase the amount of calcium resorption in the distal convoluted tubule. So thiazide diuretics can form part of the prevention plan for us. So what clinical features? Patients will present with pain, and we term this colic, and this pain will be very bad. They often rate a 9 to 10 out of 10. It will have come on suddenly, and it can radiate from the flank to the pelvic region. Patients will feel very nauseous. They might have vomited, and while they might not notice blood in their urine, if we do a urine dip, we'll find that it's positive for blood. If the stone has become infected, they might have signs of infection. So moving on to now the management and investigations with renal stones. A 30-year-old woman presents to A&E with severe flank pain. She's systemically well. A CT-KUB shows a simple 4mm ureteric stone without hydronephrosis. What is the most appropriate initial management? So I'll give about 20 to 30 seconds. So the answer for this one would be a watch and wait approach. So what we know from the question stem is that there is a 4mm ureteric stone. So this is small, and if it's below 5mm, we can be fairly confident that it will pass on its own within 4 weeks. Furthermore, she's systemically well. She doesn't have a fever, so we're not worried about an infection, and she doesn't have hydronephrosis on her scan, so we are less worried about renal impairment. So with none of the complicating signs, it being small, we can watch and wait. So before we move on to the diagram we have for the management of renal stones, let's talk about the investigations. I talked about urine dip already to look for blood, and you can also do some bloods. FPC and CRP will be useful to check for inflammatory markers to see if the patient has an infected stone. And using these will be important to find out if the stone is causing possibly a post-renal AKI. Imaging in renal stones is important, and this is a non-contrast CT-KUB, and it has to be given within 14 hours of admission. But of course, if a patient is showing signs of a fever, if they have a compromised kidney saying that they only have one kidney, or you're not sure about what's happening, you might want to expedite this. Now, as with any management scenario, you first start with the things that are bothering the patient. So there'll be a lot of pain. Analgesia will be very important. If they're dehydrated and infected, you want to do the stuff you do in a normal A2E assessment, which is fluid resuscitation and IV antibiotics. And if they are in this difficult state, you'd want to urgently refer them to urology because they need to do urgent management to try and resolve this infection/obstruction. We talked about preventions briefly. So I said thiazide diuretics, but you can also increase fluid intake. And as with gout, to reduce the amount of uric acid, you can give allopurinol long term. But more importantly, let's go into the management of renal stones now. So this is a diagram that's been created. So when you have a renal stone, we said we will check for obstruction or infection. If this is present, it's an emergency, referral to urology. And what they'll do is they'll decompress the system by doing a percutaneous nephrostomy, where they tube to the kidney and relieve any pressure that's building up. If none of these complications are present, we think about size that's shown on the CT-KUB. If it's less than 5mm, we said watch and wait, nothing to worry about. It will most likely pass on its own. But if it's bigger than that, we might have to do something about it. For stones that are bigger than 2cm, we classify these as complex or staghorn calculi. And for these, the other management techniques are not appropriate. So you have to do a percutaneous nephrolithotomy. So that's when you go through the skin to remove the stone. But if it's between 5mm and 2cm, you can do less invasive approaches. For non-pregnant individuals, this will be a lithotripsy. So shockwave lithotripsy is that when they send shockwaves to the stone to try and fragment it into smaller bits so that they'll pass on their own. In pregnant individuals, you can't do this. So instead, you'd send a scope that can sort of make the stone smaller or remove it. And that's called a uteroscopy. So when would you want to admit for renal stones? If they have a post-renal AKI, you'd be able to tell that with the Usenes. If they have uncontrollable pain, so that's not responding to analgesia, if they're infected, or if they have a large stone. So SBA3. So for this, I think Freya's got already a poll. Wonderful. I'll wait for one more answer. Fantastic. So most people have gone for E, and that is indeed the correct answer. So here we have a 30-year-old woman. She has fever and pain when urinating. She's also noticed some. So here is described as back pain on the left side, but flank can be quite a large region. So this, we have to bear in mind that this could be flank pain. And with rigors, this is very typical of an acute pyelonephritis, whereas iliopsoas abscess, the stem would normally have an indication of IV drug use to try and understand the stem of this infection. So pyelonephritis, you might remember from the previous clinical year, and it's infection of the kidney. So you'll have your lower UTI symptoms, so the dysuria, frequency, urgency, low abdominal pain, fever. But when this progresses, ascends up into the kidney, you'll have more severe symptoms such as loin pain, vomiting, rigors, and feeling very unwell. The most common cause, again, because it's a urinary tract infection, is E. coli. So what investigations do you want to do? You'll start with urinalysis as always to check for nitrites, leukocytes, and you'll send a urine MCNS. You do some bloods, inflammatory markers, and to check the renal condition of Usenes. And you might also want to do imaging to see this, if there's any anatomical abnormalities causing this infection. So a renal ultrasound might be useful. How do you manage this? Pyelonephritis can rapidly result in sepsis. So you'd want to do it in an A to E manner. This will naturally include fluids and antibiotics. And don't forget, in any A to E scenario, to make yourself an excellent candidate, don't forget about the other complaints of the patient. They'll be vomiting, they'll be in pain, give them analgesia and antiemetics. Let's move on to the bladder now. So a 50-year-old male presents with painless hematuria, and you're given the past medical history. What malignancy do you think he's at increased risk of developing? Perfect. We've got 3 answers and poll. So the majority of you have gone for the correct answer. And this was a question to try and catch you out. So the answer is squamous cell carcinoma of the bladder. And this is because the past medical history has given the stem of schistosomiasis. But you find with bladder cancer, this is a relatively rare cause of it. The most common type is a transitional cell carcinoma in up to 90% of patients. And this is describing the inner lining of the bladder, which are termed transitional cells. Significantly more rarely that you'll get a squamous cell carcinoma because of risk factors like schistosomiasis infection in the past. So how do we classify this? We separate it into non-muscle invasive and muscle invasive. And that's in keeping with how we sort of risk stratify and treat this. Non-muscle invasive, as it sounds, is it doesn't go into the muscle, it stops at most at the lamina propria. And muscle invasive goes into the muscle and perhaps even what surrounds the bladder. So risk factors, the biggest risk factor for bladder cancer is smoking. But you might also find a discussion of aromatic hydrocarbons. So if there's an industrial sort of picture as the occupation for the patient in the stem, also considered bladder cancer. And the drug to keep in mind as a risk factor for bladder cancer is cyclophosphamide. How do you present? Painless hematuria is the most common. So remember, painless hematuria is bladder cancer until proven otherwise. Patients might also present with recurrent UTIs and lower urinary tract symptoms. But if the bladder cancer has spread, developed, you might get localized symptoms, so pelvic pain, problems with the bowels perhaps. And if it's spread to the bone, you might get bone pain. And generally, as with all cancers, weight loss and lethargy have to be considered. There are specific two-week wait referral criteria for bladder cancer. It's at a lower age if you have visible hematuria, but if you have non-visible hematuria, you have to be over 60 and have at least one of dysuria or raised white cell count. So this is something that I myself only found out closer to exams, that the criteria for non-visible hematuria is actually very strict when it comes to the referral criteria for bladder cancer. How do you investigate this? As always, you start with simple investigations you do at the beginning, a urine dip to establish hematuria. And to investigate the bladder cancer itself, there are two important investigations. Everyone will get a flexible cystoscopy, and this is when they visualize what's happening in the urethra and the bladder. And they'll be sent for a CT urogram, which is a urinary tract specific CT, which can visualize it very in depth. So if you identify what you think would be a tumor, you want to do CT staging before you progress to any intervention. And what will the intervention be? Let's start with non-muscle invasive. So if your investigations find that the carcinoma is classified as T1 or CIS, which is carcinoma in situ, you want to do a TURBT. And what that is a transurethral resection of the bladder tumor. So yes, it's a surgical, it's an operation where they go through the urethra into the bladder and sort of scrape away the superficial tumor. And what they can actually do, because they're doing this, they'll have access to the tumor. They can send it for biopsy at this. They can send it for investigation, and so they can look and grade the tumor after this. If the tumor is thought to be high risk, they can also give intravesical therapy with BCG. So that's the thing, that's what is related to TB, and BCG can sort of activate the immune system to fight the cancer. And this is given into the bladder as opposed to into the blood. If it's classed as intermediate risk instead, you might want to give mitomycin C, which is a chemotherapy agent. And these patients will be followed up with cystoscopy at 3 months, 9 months, and then every year for 5 years to make sure that there's no recurrence of the tumor. However, if it's muscle invasive, we have to take this more seriously because the survival rate immediately drops significantly because it's invaded into the muscle. So you'd want to do a big surgical procedure, which is a radical cystectomy with urinary diversion. So they remove the bladder in its entirety, and they have to then find a way to deal with the urine output from the kidneys. So what they do is they create a little pocket in the ileum and and that acts as a reservoir. Then they can do a urostomy to then allow the urine to leave your body. With muscle invasive, often what's done before this big surgical procedure is that you're given neoadjuvant chemo, and that's to try and reduce the burden of the muscle invasive cancer as much as possible. So now we're moving on to a topic of urinary incontinence. So we have an SBA to start this. Just waiting for a few more answers. Just 10 more seconds. We'll solve the poll there. So the correct answer is bladder diarrhea. So when you approach this question, we see that it's describing incontinence here. So you want to then first think about what type of incontinence is it describing. So getting a sudden urge to pass urine and not making it to the toilet in time sounds like an urge incontinence as opposed to the other types that we'll go through. So once we've identified as urge incontinence, what do we think is the first management step? So we want to, as clinicians, we want to get the idea of how often is this happening, when is this happening? So a bladder diary will be really useful. So the different types, we'll start with urge because that was related to the question. So what happens in urge is that the detrusor muscle in the bladder is overactive. So the bladder keeps contracting and this causes an increase in pressure inside the bladder. And as a result, urine leaks, sometimes without voluntary control. So if it's stress, however, this is because of intra-abdominal pressure, which is causing the pressure in the urethra, and activities such as coughing, laughing, lifting will cause leakage. Often in reality, though, it can be a mixed pattern between stress and urge, and that makes it somewhat harder to treat. The other important things, types of incontinence here, include functional. You'll find that most in your exam. So that's when patients can't get to their toilet in time because of other issues. So it's not that they have intrinsic urinary tract disease, but because they might have difficulty mobilizing or they might have cognitive impairment, they often can't physically get themselves to the toilet and as a result have incontinence because of that. So initial approach, as always, a detailed history. A bladder diary for 3 days will be very useful. And then we move on to investigations. As with anything in urology, urine dip is vital in primary care especially. And if we suspect overflow, incontinence, so that's with chronic retention, when the efferent fibers don't work as well. And as a result, you collect more and more urine, which leaks. You might want to do a post-void bladder scan. And moving on from this, urodynamics can be really useful for urge, overflow, incontinence because it looks at the pressures inside the muscles and the bladder and also the rate of outflow. So these are quite complicated tests that can be interpreted by urologists to try and give an idea of what the pathophysiology is. So there are some general management points that apply to any type of incontinence. And these are mostly lifestyle focused, so weight loss, reduction of caffeine, and avoiding excessive fluid volumes, especially at night, can go a long way to helping the symptoms. And in any OSCE situation, you'd always want to start with what you do conservatively. So that includes these lifestyle measures. And then we move on to medical and surgical. So this slide is focusing on the two most likely ones you're going to encounter, and this is stress and urge. So stress often happens postpartum because of long-term rise in intra-abdominal pressure, can also happen in obesity because of the same reason, and constipation. Whereas urge can have a neurogenic element, but often it's just idiopathic. So what do we do for stress incontinence? We start with advising pelvic floor muscle training. And this should be tried for at least 3 months. So a lot of questions in your exams can trip you up with the length of time that the patient's been trying this for before moving on to medical management. So you always have to keep in mind for stress incontinence, you have to have tried pelvic floor muscle training for 3 months. And then we can move on to giving duloxetine, which is an SNRI. And this can actually help reduce the leakage because it will strengthen the stimulation for the urethra to contract. If this doesn't work, there are complex surgical management techniques. In urge incontinence, it's not pelvic floor muscle training which is tried, but instead bladder training, and this is for at least 6 weeks. And because bladder training is often not the most useful or most successful, antimuscarinic, so anticholinergic drugs are often moved on to quite quickly, and this can include oxybutynin most commonly. So what do the anticholinergics do? They inhibit the contraction of the detrusor muscle in the bladder, and as a result, get to the root of the problem causing the urge incontinence. But you might find that in elderly individuals, you want to avoid anticholinergics. And that's because of the anticholinergic burden, which can increase the risk of falls, increase the risk of confusion. And in these patients, you might want to try mirabegron instead, which is a beta-3 agonist. Again, if these don't work, you can try Botox and other surgical techniques. But your exam is unlikely to focus on these surgical managements. So it's just a good idea to get the basics of the medical management and the conservative management really well. Great. So having covered the bladder and the kidney, we can move on to the prostate now. And we have our 6th SBA. Great. So the correct answer is indeed BPH. And just the reason for this is because we have a 60-year-old man. He's waking up at night to pass urine. He has a weak flow. He has intermittent stream and some dribbling. And when you do a rectal examination, you notice a smooth enlarged prostate. So this smooth enlarged prostate is typical of a benign prostatic hyperplasia, and the various lower urinary tract symptoms he's describing also is the common presenting complaint of BPH. So let's talk about BPH. So the symptoms it presents with can be a mix of storage and voiding symptoms. And together, storage and voiding symptoms are what we think lower urinary tract symptoms are. So storage can present as frequency, urgency, passing urine at night. But voiding is when you have difficulty expelling the urine. So they can be hesitant, the stream can be weak. Once the patient feels like they've finished passing urine, they might notice some extra dribbling, or they might feel that they haven't emptied their bladder completely. And the DRE is the key differentiator here. So what you feel in BPH is the prostate is benignly enlarged. So you'd feel a smooth symmetrical enlargement. And importantly, you'll feel the dip between the two lobes of the prostate, and this is the median sulcus. Because BPH, the prostate wraps around the urethra, so it can compress the urethra, and as a result, the back pressure can cause a palpable or percussible bladder if some sort of retention is going on. How to investigate this? We always start with urinalysis. You want to do bloods to see if this possible obstruction that is BPH is affecting the renal function. And you might also want to do an ultrasound to get a better idea of the prostate volume, see if the bladder is enlarged because of retention, or if this back pressure is going all the way to the kidneys, causing hydronephrosis. So the main complications we've discussed is acute urinary retentions, because BPH is a key post-renal AKI cause. Over a longer time, chronic retention is a complication. As always, conservative management begins with reducing fluid intake, reducing caffeine and alcohol, but the medical management is the key thing you'll need to remember here. So we start with alpha antagonists, and the key one uses tamsulosin, but you might also find rarely doxazosin on patients' drug history. So how does this work? So this relaxes the smooth muscle of the bladder and the urethra, and it starts to work very quickly. So it's if a person's having these symptoms, tamsulosin can relieve their symptoms very quickly, but you might, as expected with an alpha adrenal receptor blocker, you might get the side effects of postural hypotension, and you might also get retrograde ejaculation because you're relaxing the smooth muscle of the urethra and of the urethra in particular. Over a longer period of time, if the prostate is sufficiently big, so the cutoff is at 30 cc's, you might want to give a 5-alpha reductase inhibitor. So the most common one is finasteride. And the reason that you give finasteride is because you're trying to target the key cause of what's making this prostate get larger. And this is testosterone DHT driven. So if you block 5-alpha reductase, which converts testosterone to DHT, you can reduce the prostate size. But this takes a long time to work, and you might notice because you're reducing testosterone-related hormones, you'll get effects of erectile dysfunction, reduced libido, ejaculation problems, and gynecomastia because you're reducing the estrogen to androgen ratio. But you're increasing the estrogen to androgen ratio because you're dropping the androgen levels. If this doesn't work, you might counterintuitively give an anticholinergic like oxybutynin to try and relax the bladder further. So the gold standard is actually surgery, though, and this is TURP, a transurethral resection of the prostate. But the complications can include bleeding, infection, erectile dysfunction, retrograde ejaculation. What a TURP essentially is they go through they go inside the penis through the urethra, and then they shave off the prostate from the inside, so the prostatic urethra, because the prostate tissue is continuous with the urethral tissue at that point, so you can shave it off from the inside, which is where the hyperplasia is most common. But if the prostate's too big, you have to do an open removal of the prostate. In SPAs, they like to allude to TURP syndrome. Now, when you're doing the surgery, you have to give a lot of irrigation, and the fluid you give in the irrigation is hypoosmolar. So what happens, because this fluid is hypoosmolar, it often moves from the urethra, can move into the circulation, and too much fluid in the circulation will cause overload and a dilution of hyponatremia, and you'll get symptoms of hyponatremia such as confusion, nausea, agitation, and visual changes. So keep an eye out for TURP syndrome in a patient that's recently undergone this procedure. So with BPH, you then have to be in the spectrum of prostate disease, you have to be worried about prostate cancer. Now, prostate cancer is mostly adenocarcinoma and mostly in the peripheral zone. And this is important because most of it's in the peripheral zone, you'll be able to feel it when you do a rectal examination, and you'll feel a nodular, irregular prostate. So risk factors: age, Black ethnicity, family history, and very SBA-able is the BRCA1 and 2 gene, whereas exercise is considered protective. So what are the clinical features? You'll get the lower urinary tract symptoms like we described for BPH. This can include frequency, urgency, but also terminal dribbling, hesitancy, and prostate cancer can actually spread to metastasize to the bones. You might get bone pain as a presenting symptom. How do we investigate this? We start with a DRE, like I mentioned, and you do a PSA. Now, the PSA is a test that they can give you in an OSCE, they can give you an SBA. PSA has a very low sensitivity, but a relatively high specificity. So what that means is that PSA in patients that have prostate cancer, in patients you suspect have prostate cancer, negative PSA will almost exclude prostate cancer, but PSA can be raised for such a multitude of reasons. Under a third of patients that have a raised PSA actually have prostate cancer. So it can be a difficult test to interpret. It can be raised in BPH, prostatitis, vigorous exercise, recent ejaculation. It's very difficult to use prostate PSA as a diagnostic test for prostate cancer, but it can certainly give a very good indication. And because of that, it's used in the 2-week wait referrals. So if the DRE reveals examination findings consistent with prostate cancer, or the PSA levels are above the age range cutoff level, you'll refer them onwards. And what will happen onwards is a multiparametric MRI, which will give you a new score, which is the Linus scale. And if the score is more than a cutoff of 3 out of 5, you can do a prostate biopsy. So you can take a look at those prostate cells better. So when they look at the cells better, they come up with a Gleason score. Now, Gleason score goes from 1 to 5, but 1 and 2 are not used at all. So the lowest score you can get will, the way you calculate the score is you take the first and the second most common cell types you've seen. So the lowest score will be a 3 plus 3. And what this will mean is that this low score, this intermediate zone, moderately differentiated, is not that different from the normal prostate cells. So we wouldn't really do anything about it. It's very, very low risk. If the two numbers added together are 8, that's intermediate risk, 7 to 8 is intermediate risk, and 9 or 10 are high risk. But the vast majority fall in this low risk category. Gleason might not be used that much anymore, and there is a role for TNM, just as with other cancers. How do we treat it? If it's a T1/T2, a localized one, there is an element of active monitoring. So this is regular PSA, regular DRE examinations, and maybe a biopsy if the patient would prefer every couple of years. But if there are complications, you might want to do surgery, but this is rare because prostate cancer can be very slow growing. If the prostate cancer is more advanced or it's metastatic, you'll have to consider what you should do. If it's not metastatic, but it's locally advanced, so it's more high risk, you want to remove the prostate with a radical prostatectomy. If it's metastatic, removing the prostate doesn't address the fact that there's been metastases, so hormonal therapy has a big role here. And that's because we know that prostate cancer is androgen driven. So if you shut off the androgen supply, you might be able to reduce the symptoms and get it under control. So you want to give a GnRH agonist, so goserelin, which will shut down the axis producing androgen. But before it shuts down the axis, it can cause an initial rise in androgen. So you want to cover this initial rise before the subsequent fall with an anti-androgen agent. So you can use a non-steroidal anti-androgen like bicalutamide. There's also a role for removal of the testicles, so an orchidectomy, because they are ultimately the source of your production of testosterone, but this is not done as much. So now we've talked about urinary retention, and this is an SPA looking at that. Indeed, the answer is E. So this patient has presented with suprapubic pain a week after starting amitriptyline. He can't pass urine, so we feel this could be acute urinary retention. So amitriptyline has a big anticholinergic burden, so this could be contributing a medication cause of acute urinary retention. So how would you want to ease this? Because the bladder's not contracting, because you're inhibiting the detrusor, you'll have to physically remove the urine, and a catheter will do that. So acute urinary retention, we have to think about the etiology. This is the most important part in urinary retention. If it's obstructive, it could be obstructive. So we talked about BPH, a stricture which can develop post procedure, or even a calculi, so a stone like we discussed. Could be medication, so anticholinergics, amitriptyline, which is a TCA, has a big anticholinergic effect too. It could be a neurological cause, such as multiple sclerosis or upper motor neuron disease. So when thinking about the cause of acute urinary retention, split into obstructive, medication, and neurological. The symptoms, just like in the stem, patients can't pass urine, they have lower abdominal pain. But if they're chronic retainers, they won't have this pain. But if they're in an acute situation, they will. They could have a palpable distended bladder when you examine them. And what would you want to do? You want to do, if you can, a urinalysis. You want to do Usene's bloods, and you want to do a bladder scan, importantly, to find out the volume of urine they're retaining. And if you're worried that there could be some features of high pressure retention and reflux of the collecting urine, this could result in hydronephrosis, which is enlarging of the kidney. So you want to do an ultrasound scan. So when draining this urine with a catheter, you're worried about post-obstructive diuresis. And that's when you're passing too much urine post an obstruction, and this can cause volume depletion in your blood and cause a worsening AKI. So in this scenario, you'd replace the fluids. So how do you manage it? We discussed the ultrasound, and this is the volume to correct retention. And once you put a catheter, you want to measure the volume drained in 15 minutes. And depending on how much is drained, this will guide whether you should leave the catheter or remove it. Once the catheter's been in and you made sure the user needs that there's no problems with the kidneys, you might want to try a trial without catheter for 48 hours. And if the patient's fine, they keep on passing urine, they don't go back in retention, you've solved the problem. But if they do go back in retention, you might have to do a long-term catheter for the patient. And depending on the cause, refer to the relevant specialty. So swiftly onto the genital tract with another SBA. Correct. The answer is indeed D. So here we have what sounds like a testicular torsion, and we know this because there is a trigger of trauma. There's severe pain, which is a sudden onset, and the left testicle seems to be higher than the right. So a high-lying testicle is an indication that you have testicular torsion. In this case, because you're worried about testicular infarction and subsequent necrosis, urology need to do their exploration urgently. So before we talk about torsion, let's talk about epididymitis, which is inflammation of the epididymis. This has a bimodal distribution. Early age, 15 to 30, where it could be STI related, and after 60, when it could be UTI related. So this could either, as I said, be due to gonorrhea or chlamydia for younger males, but if it's for older males, it could be more UTI, so E. coli related. Symptoms are quite similar to torsion, so scrotal pain, swelling, maybe a low-grade fever. And if you're not sure if it's epididymitis or testicular torsion, you need to rule out testicular torsion. And this could be either via ultrasound or even surgical exploration. So in an examination, there are some things we can try and give you an indication of what's going on. With epididymitis, the cremasteric reflex is intact. So this is when sensation to the medial thigh can cause a raise of the penis, and Prem's test could be positive, so the pain relieves when you raise the testicles. But these are unreliable signs, so it's difficult to determine sometimes. What would you do? you do a urine dipstick as always. If you suspect epididymitis of an STI origin, you want to do a NAT. As Freya will go on to when she discusses sexual health, the nucleic acid amplification test is first void. Urine is the first line diagnosis test for gonorrhea, chlamydia in men. You also can do general bloods to check for inflammatory markers, and an ultrasound Doppler will confirm. How do you manage these? Antibiotics, analgesia, bed rest, and scrotal support, and refraining from sexual activity until you complete the course of antibiotics. If you suspect an UTI, you want to give fluoroquinolone like ofloxacin. If you suspect an STI, you want to cover both chlamydia and gonorrhea. So you want to give ceftriaxone for the gonorrhea side and doxycycline for the chlamydia side. Torsion, however, this is a very important diagnosis not to miss, and you will definitely be tested on it. It needs to be acted upon within 6 hours, because if left untreated, the blood supply is compromised. So this torsion is when the spermatic cord and its contents twist within the tunica vaginalis, and as a result, you impair the venous return, and the venous supply gets congested, causes edema and subsequent infarction. You might find in the SBA that the bell clapper deformity is mentioned, and this is a horizontal lying testes, which doesn't attach to the tunica vaginalis normally. So this means that it's more mobile, it can move, and it might undergo torsion more easily. So how do they present? Similar to the stem, sudden onset severe unilateral testicular pain. They might also have nausea and vomiting. The testes may lie higher than it would normally, and it might be horizontally instead of vertically. The cremasteric reflex will be negative, as will the Prenz test. This is a clinical diagnosis. That's because the time you need to find this out to treat it. So you can't wait for investigations. But if it's unclear, you might want to do a Doppler ultrasound. The urgent surgical exploration is the management. So the urologist will cut into the testicles and they'll visualize whether it has undergone torsion or not. If it has, you do a bilateral orchidopexy. That's when you fix the testicle to the scrotum to prevent further torsion. And you do it to both of them, even if you have symptoms in one, because if you have torsion in one testicle, there's a very high risk you'll get in the other in the subsequent future. So when consenting patients for this surgery, you have to explain to them that there may be chronic pain associated with the surgical procedure. They might be able to feel a suture in their testicles, and there remains a fertility risk, despite even if you've done it within a relevant window, because there has been a period of time in which the testes has had impaired blood supply. And so testicular cancer is the other important condition you need to think about. So it's a common cancer in males aged 20 to 40, and the risk factors include undescended testes, family history, Klinefelter syndrome, which is XYY, and a mumps orchitis. Most testicular cancers are germ cells, and there's fairly equal between seminomas and non-seminomas. And a very small amount can be non-germ cells. So the important ones to know here are typically seminomas and non-seminomas. So the overarching names, instead of knowing embryonal yolk sac teratoma, choriocarcinoma, is rare that these will come up. Just know the overarching names. And seminomas tend to stay localized until late, so they have a good prognosis, whereas non-seminomas can metastasize earlier. So of course that leads to a worse prognosis. What might you feel? You might feel a painless testicular lump. So this will be irregular in size, will be firm, will be fixed. It won't illuminate like a hydrocele would. You might notice gynecomastia or signs of metastases. You might not notice lymphadenopathy, which is a feature of cancers in general, because the testes actually drain to the para-aortic lymph nodes. So you might not notice the lymph nodes around the groin. What's the first investigation you do? You do assessment of the soft tissue, so the ultrasound of the scrotum will be the best. And you can also do some tumor markers, which are more rare than the non-seminomas. So beta HCG, AFP, and LDH. And as always, TNM is a key staging technique. How do you manage these? as with any cancer, and as in any OSCE, you'd say an MDT approach. But the most likely surgical management will be an inguinal radical orchidectomy, so a removal of the testicle. This might be supplemented with chemo if there's high-risk features or if it's metastatic spread, and regular surveillance. But as always, when you receive radio and chemotherapy, you have the complication of a possible secondary malignancy in either in the blood or in the local tissues. And as always, with testicular cancer, you're removing a testicle, so you have to think about the long-term fertility plans. So a fertility assessment is often very useful, so you can have semen analysis and preservation, so that this doesn't affect patients down the line. So wrapping up urology quickly, with other testicular swellings, we've been through testicular torsion, we've been through epididymitis, and this is the transillumination which I mentioned previously, and it was the hydrocele. So you can look through this in your own time, but it's a nice diagram that maps the scrotal swelling into the symptoms, and you can get to your ultimate diagnosis. But the general features can include, with an inguinal hernia, you might notice a cough impulse, if you remember from last year. With the epididymal cysts, they can be single or multiple, but they're usually painless, small, and positioned above and behind the testes. And these can be excised if causing problems. A hydrocele is soft, fluctuant, and is clear fluid that overlies the testes, and you can actually trans-illuminate, so the fluid inside it will illuminate when you apply a light source to it. Varicocele, so that is when there is impaired venous drainage, and you can feel like a bag of worms between your hands. And it's usually on the left side because anatomically the left testicular vein drains into the renal vein instead of the main veins. And it may be, because it drains into the renal vein, it can be a presenting sign of renal cell carcinoma. Often, it's just conservative management for this, but if there is bilateral varicoceles or there's worries about fertility, you might want to do surgery or interventional radiology to embolize these veins. Now, I'm just going to skim through this because it's unlikely to come up. So balanitis and balanopostitis is inflammation of the glans penis. And if there's also inflammation on the underside of the foreskin, you say balanopostitis. It can be infected with candida, bacteria, or anaerobes, or it can be inflammatory with skin conditions, lichen planus, or lichen sclerosis. It's mostly a clinical diagnosis, but depending on the specific cause, there's further treatment. And you can look at this in your own time. It's not the most high yield, but might be 1 or 2 marks. What is high yield is another emergency in urology, is paraphimosis. So paraphimosis is when let's start with phimosis. It's easy to visualize it that way. So phimosis is when you can't retract the foreskin. But if the foreskin is already retracted and then you can't replace it, that's paraphimosis, and paraphimosis is the true emergency. That is because when you have paraphimosis, you have a tight constricting band in the foreskin that prevents retraction. So you have reduced venous return, engorgement of the distal penis, and the glans becomes edematous. So this can result in ischemia and infection. And because of the progressing ischemia and pain, you will notice, sorry, because of the progressing ischemia and edema, you'll notice progressive pain and swelling in the glands. So the management is to get urology there ASAP to reduce the paraphimosis. Analgesia with possibly a penile block needs to be used, and you can try and reduce it manually, but mostly you'll need a dextrose-soaked gauze because there's dextrose inside it. Fluid will be drawn out of the glands by osmosis, and you can also puncture needles into the glands to drain the fluid. If none of this works, an emergency circumcision will be needed. But regardless, even if you haven't circumcised them acutely, in the long term, to prevent that happening again, you will need to do a circumcision. Great. So I'm going to start gum briefly, and then Freya's going to continue it. And we're mostly going to cover chlamydia, gonorrhea, the high yield ones, and then we'll skim through the hepatitis. So a 23-year-old woman attends the gum clinic with vaginal discharge and dysuria. Her partner recently had an STI, so what's the most appropriate investigation to confirm the most likely diagnosis? So I mentioned this previously in the urology section when we were looking at epididymitis STI causes in younger males, and the answer is a chlamydia gnat. So a nucleic acid amplification test. So chlamydia is the most common STI in the UK. In most people, it's asymptomatic, but if it does have symptoms, it'll be for women, discharge, bleeding, pain when urinating, and for men, discharge coming from the urethra and also pain in urinating. The complications of chlamydia include epididymitis, which we've already discussed. In women, it can ascend and cause pelvic inflammatory disease and also endometritis. If you remember back to a room last year, chlamydia can also cause reactive arthritis, which is arthritis, urethritis, and uveitis or conjunctivitis. I'll need to double check that. But the investigations will be the NATs. For men, you want to do a first void urine sample, but for women, you want to do a vulvovaginal swab. And how do you manage this? It used to be azithromycin for chlamydia, but now because of resistance, doxycycline is the first line agent. But if you remember correctly, in pregnant women, you can't give doxycycline, so you'd still persist with the azithromycin in that case. And in gum, it's very important to, in an OSCE situation, consider the wider impact. So contact tracing is essential because the treat and test approach is done for partners of this person that's been recently diagnosed with chlamydia. So do not forget to mention contact tracing in an OSCE scenario regarding a recently diagnosed STI. Gonorrhea is the second most common, and it's a gram-negative diplococcus, and it has more symptoms than chlamydia. So similar sounding symptoms, however, which is discharge for women and men, and possibly pain when urinating. And the complications are also similar, but it's important to remember disseminated infection, which we'll go over in the next slide. You will also investigate this with a NAT, a nucleic acid amplification test, first void for men, vulvovaginal for women. And the treatment for this is IM ceftriaxone, but if this is refused because they don't want a needle, you want to give cefixime and azithromycin. And remember contact tracing. Now, disseminated gonorrhea is very interesting, and it can present as an arthritis affecting joints. And the triad that is typically known is tenosynovitis, so the ligaments, dermatitis, the skin, and polyarthralgia, so affecting many joints, and it can have systemic symptoms with it. So when there's a disseminated gonorrhea infection, you want to do blood cultures and NATs to try and find the gonorrhea in either the urogenital system or the rectal system or the pharyngeal system. For this, instead of one of those of IM ceftriaxone, which was in gonorrhea, disseminated gonorrhea needs this every 24 hours for 7 days. And if there's a septic arthritis picture, you also need to joint aspirate and joint drain. So that's the end of my section. If you don't mind filling out this feedback, Freya will continue from here.
Okay, can you hear me?
Yeah,
Okay, I'm just gonna start. And you can see the slides.
yeah,
Okay. So I'm just gonna go through the SBA instead of doing the poll. So this is a 28-year-old woman presenting with a fishy, thin, grey vaginal discharge. And the pH of the discharge is greater than 4.5. So what is the most appropriate management? So what this question is trying to get at is what could this woman potentially be experiencing? And then what is used to treat it? So the thing that really gives it away is the fishy, thin grey vaginal discharge. And then this is confirmed with the pH greater than 4.5. And we should be thinking of something called bacterial vaginosis. And the thing that's used to treat it is oral metronidazole. So in this slide, we can see some of the 3 more common causes of vaginal discharge. There are obviously other causes of vaginal discharge as well. But the SBA was referring to bacterial vaginosis. So this is not actually an STI, but it's usually always seen in sexually active women and not in those who aren't sexually active. The reason it's not an STI is because it's due to an imbalance of the vaginal microorganisms. So normally the microorganisms within the vagina produce lactic acid and create kind of like an acidic environment. However, in BV, there is a proliferation of an anaerobe called Gardnerella, which causes the lactic acid to fall, which is why you have a higher pH greater than 4.5. Some of the clinical features would be the fishy, offensive smelling discharge, but in some people it can be asymptomatic. In those where BV is asymptomatic, it may not necessarily need to be treated, so it's important to kind of keep that in mind. It's diagnosed using the Amsel's criteria, and you need 3 out of the 4. So you need the discharge, you need clue cells on microscopy, which the next slide will show, a vaginal pH greater than 4.5, and a positive whiff test. So like a positive smell test, basically. So when you add potassium hydroxide to the discharge, it would produce a fishy odor. And in order to treat it, you would need oral metronidazole for 5 to 7 days. And some of the alternatives are topical metronidazole, or if they can't have metronidazole, then clindamycin as well. And it can relapse as well, so it's important to keep that in mind. The thing that BV is kind of sometimes confused with is trichomonas, and that's because trichomonas also has a discharge with a pH greater than 4.5. But they're caused by different things. So in trichomonas, it is an STI, unlike BV, and it's caused by a protozoan parasite. It produces a frothy yellow-green vaginal discharge, and most notably, it has a strawberry cervix, which you can see on speculum in some patients, where the cervix is kind of pale, pink-looking, and then there are dots of kind of red spots across it, which indicate bleeding. And you don't need to necessarily do an investigation for it, but you can do a microscopy for it. It's also treated with the same thing that BV is treated for. So if in the previous SBA you thought you weren't sure if it was trichomonas or BV, you would have ended up with the same answer anyway. In men, trichomonas can kind of just present as urethritis, so discharge, pain while peeing, general STI-like symptoms. Something else that can cause discharge is vaginal candida. So this is quite common, and it's caused in 80% of cases by Candida albicans. It can be due to underlying risk factors, like if you have diabetes, or if you're on steroids that suppress the immune system, or if you have immunosuppressive conditions like HIV, then you could be more likely to get it. But if you have a one-off episode for it, it doesn't necessarily mean you have any of these risk factors. It is most notably, you can see like a cottage cheese non-offensive discharge. So it doesn't smell, but it looks very unique. And this can be very irritative to the vulva, so it can cause a lot of itching and redness, and people may need to itch so much that it causes like tearing, so there may be also some bleeding of the skin, and patients would also be suffering with pain during sex and pain when they're going for a wee, for example. So these are important things to ask. Also for vaginal candida, it really needs like an estrogen environment, so it's not very common in people who haven't started their period yet, or women who are postmenopausal. So again, important to keep in mind when it can present similarly to some other vaginal differentials. So it's diagnosed clinically, and you don't need to do a swab. You may only need to do swab or microscopy if you keep having repeat infections, which we'll cover in the next few slides. And in order to treat it, you need some form of antifungal. Now, this can be given in the form of a pessary, which can be done for any woman, but it's always done if you have candida and you're pregnant, because it's contraindicated to take the oral antifungals. And then there are 2 oral antifungal options. You can either take 2 tablets of itraconazole just one day, or you can just take 1 tablet of fluconazole, and that should treat it. So you can see on this slide that this is the signature clue cells for BV on microscopy. This is the protozoa for Trichomonas, and this is yeast for Candida. So BV during pregnancy is important to keep in mind because it can have quite a lot of implications. It can increase the risk of preterm labor. It can also increase the risk of pre-labor rupture of membranes, which obviously has its own complications. It can increase risk of chorioamnionitis and also cause a baby with like a low birth weight. Even postpartum, it can increase your risk of endometritis. So if you have BV during pregnancy, even if you're not symptomatic, you would most likely be treated with oral metronidazole. And because of the underlying risk factors for vaginal candida, if you have had like more than 4 episodes of it within a year, you would not only want to just check the compliance and investigate with microscopy and culture, you would also want to do testing for diabetes or think about other differentials that it could have potentially been misdiagnosed for. And if it is in fact candida, then you may want to give a longer dose of antifungals. Just remember when doing that, antifungals can definitely affect the liver, so LFTs are important before, during, and after when you're taking long-term antifungals. So moving on to herpes simplex virus, so most commonly known as genital herpes. There are 2 viruses that can cause it, HSV1 and HSV2. They're both part of the same family, but the one that's more common is HSV2, and it can cause oral, genital, or ocular ulcers, and they're transmitted via contact with the lesions. So the way they, where you get them really depends on what sexual activity you contracted them through. So the primary symptoms, which is what happens when you first get infected with HSV, happen 4 to 7 days after your exposure to it. So the primary symptoms normally consist of multiple painful blisters, usually on external genitalia. In women, sometimes it can be just in the cervix, so it can be missed, but they would experience pain during urination and pain during sex as well. They would also potentially have some discharge and just general fever and malaise, so it would be picked up hopefully that way. Otherwise, it's a very external looking rash that is quite easy to identify. It can last up to 20 days, and after the primary episode, the virus can become latent, so it travels up the local sensory ganglia. For the case of HSV2, it travels to the sacral ganglia, and it resides there until it can potentially become reactivated due to any kind of stress or viral infection that the patient may be going through, and it can reappear. And similarly to like shingles, when it reappears for the like with a dermatome or like a specific anatomical location, because of depending on where, like which neuron it was residing in. And normally the episodes when they reoccur are not as severe, because the symptoms are less systemic. So they may not necessarily need to be treated, but it depends on how many recurrent episodes they're having. In terms of investigations, you'd want to do a PCR and viral culture. Something that kind of sometimes comes up in questions is something called a Zank smear. I've seen this come up for HSV. And if you did that on an HSV, it would show multinucleated cells, which sometimes have these things called Cowdrier bodies. So these are just keywords to remember for SBA land. I don't think I've seen them anywhere else, or whether it's even done in practice. In terms of the management, you would want to advise conservative things like saline bathing, giving meds to kind of help manage the pain, and also topical numbing agents. And you can also give oral antivirals, and you have to kind of adjust the length of the treatment depending on whether they're still actively producing new lesions or not. And then if they have recurrent episodes, you'd want them to continue to taking care of themselves with the conservative measures you advise them earlier. But if they're having greater than 6 attacks per year, you could consider giving a very long term of antivirals in order to hopefully suppress the virus. So HSV, if you contracted that during pregnancy, if your primary exposure to it happened greater than 28 weeks into the pregnancy, you would want to do something called an elective C-section. And the reason you want to do that is to avoid the risk of neonatal herpes, which is a very rare phenomenon, but it can happen. And it can cause, because HSV, like I said earlier, is contracted by contact with lesions. If a mother has active HSV genital lesions and she does a normal labor, then when the baby comes out of the vagina, it can obviously make contact with the genital lesions, and it can, contract HSV and then develop neonatal herpes. And this is normally seen as genital lesions on the scalp, the eyelids, and the mucosa, like the oral mucosa. So you'd want to prevent that, because in some cases it can go on to developing meningoencephalitis. So in order to avoid this, we say that if a woman has had her primary attack of HSV greater than 28 weeks during her pregnancy, then she would need to do an elective C-section. If, however, somebody has HSV before they're pregnant, we would want to carry on treating the HSV if it causes any issues at the beginning of the pregnancy with antivirals, because if you suppress the HSV, transmission to the baby is very low. So you'd want to reassure the mother if that was the case. Okay, and I'm just going to go through this question. So this is a 30-year-old man who presents with a widespread maculopapular rash, including his hands and soles, along with a headache and a lump in his groin. Around 6 weeks ago, he also had a solitary painless ulcer on his penis. So what is the most likely diagnosis? So as you can kind of guess from some of the options, what this man has is syphilis. And the question's also asking you to differentiate between the 3 stages of syphilis. The answer to this is secondary syphilis. And the reason, what really gives it away, is the widespread maculopapular rash, as well as the fact that 6 weeks ago he had a solitary painless ulcer on his penis. So syphilis is a bacterial infection caused by Treponema pallidum, which is like a spirochete, which is like a spiral-shaped bacteria. It has quite a long incubation period, and it has 3 main stages. So in its primary stage, which happens about 1 to 3 weeks after the bacteria lands on skin, it can cause a painless ulcer at the site of sexual contact. So or at the site of whatever contact they had. So it doesn't necessarily have to be in a genital area. It could also be around the mouth, for example. And along with this, there would be local non-tender lymphadenopathy. And then the secondary stage consists of once the spirochete has kind of made its way to the surface, it will go into the bloodstream. And this happens about 6 to 10 weeks after the primary infection. And during this time, the person is most infective. So they're more likely to transmit their syphilis onto somebody else. And that's because the bacteria is within the blood. And when it's in the blood, it can bind on to the endothelial cells of the vessels and then manifest as a non-itchy maculopapular rash on the skin, which normally starts off on the trunk, then moves to your arms and legs, and then the palms and soles of your hands and feet. And you can also get snail track ulcers in the mouth and something called, and basically, I know the rash starts off as maculopapular, but the rash can carry on progressing in different ways. So it could become like a pustular rash. It could also turn hard and scaly. And it can also turn into something called condylomata lata, which is like painless, warty lesions on the genitalia. So the rash can change its shape and type. And then syphilis kind of becomes latent. So there's an early latent phase, which is within like a year of contracting syphilis, and then a late latent phase, which is like a year after. But after this point, you enter something called tertiary syphilis, which, as you can see from the top of the slide, it's greater than 2 years after the primary infection. And you only progress to, any of these stages if the patient is left untreated. But essentially what happens is that between the secondary and the tertiary stage, during the latent phase, the bacteria kind of goes away from the bloodstream and enters certain organ systems, for example, heart, the liver, the bones, and it kind of resides there. However, there are a few spirochetes obviously left within the bloodstream, and these cause a really, really big reaction from the immune system in the body, almost like a type 4 hypersensitivity reaction. And it causes these gummers to form, which are granulomatous lesions. And essentially, they're trying to attack syphilis, but they don't actually have any of it inside. It's just a massive bunch of inflammatory cells. And these can manifest as skin lesions and can cause issues in the heart and worsen cardiovascular syphilis and also cause neurosyphilis as well. So in this picture, you can see the painless ulcer on the skin, which is a chancre. Like I said, it doesn't have to be in the genital area. This is the first site of contact for the syphilis to kind of get into the body. Then you can see the maculopapular rash and the snail track ulcers in the mouth, which both indicate secondary syphilis. And then finally, to the right, you can see the gummatous lesion on the skin. And you also have something called tabes dorsalis, which is when these gummers start to attack the posterior part of your spinal column. And it can therefore affect the dorsal column, so it affects your ability to sense anything, and also affects your vibration and proprioception sensors. So syphilis has many manifestations in its symptoms, especially when it reaches tertiary syphilis. In terms of diagnosing syphilis, it can get a bit confusing, but to keep it simple, there are 2 types of tests. One is specific to syphilis and the other one isn't. So syphilis itself has 3 antigens that it can present with, and one of these antigens is called the cardiolipin antigen, and this has a lot of overlap with some of the antigens found within the body and also found within certain diseases. So it's not the best at picking up syphilis. So I think the best way to explain these tests is to just go through examples. So if your non-treponemal specific antigen, a specific test is positive, and your treponemal specific test is also positive, then that could indicate that you have a syphilis, you have active syphilis in you. If your non-treponemal specific test is positive, but the treponemal specific test is negative, because the specific test is obviously more specific for syphilis, it would mean that you could potentially have a false positive, for syphilis, and you may not actually have syphilis. And the non-treponemal specific test, if that's negative and the treponemal specific test is positive, that means that you've been treated with syphilis, because the treponemal specific test remains positive after treatment, whereas the non-treponemal specific test becomes negative after treatment and even just declines over time, like whether you have treated the syphilis or not. So I think those three examples are the best way to understand the syphilis diagnosis. In terms of the management, penicillins are used. So normally it's just one dose of IM penicillin. Alternatively, if they're scared of needles or if they have a penicillin allergy, then you can give doxycycline for 14 days. Something to look out for is a Jarisch-Herxheimer reaction, which is when there's almost like an anaphylaxis style reaction, but it isn't actually anaphylaxis because there's no wheeze or hypotension. And you'd probably want to give them some paracetamol to manage the high fever. But essentially it happens because the bacteria is dying and it's releasing endotoxins to kind of fight back. And if somebody has progressed to tertiary syphilis, then they would need like a longer course of penicillin, depending on, what they have. In terms of monitoring to see whether the penicillins have been working to combat the syphilis, you would want to look at the non-treponemal specific tests, like the cardiolipin test, and check for a 4-fold decline. So it should go, for example, from 1 to 16 to 1 to 4. If it doesn't decrease by 4-fold, you could be thinking whether that person has been reinfected, or if they're taking like a longer course of penicillin, are they potentially not being compliant, etc. And because syphilis is an STI, you would want to note and check the kind of partners that they've had within the last 3 months for primary. If they're coming to you with primary syphilis, if they're coming to you with secondary syphilis, you need to extend that up to 2 years because of such a long incubation period. And asymptomatic contact should be offered treatment and rescreening as well, because it has a latent phase as well. So even if they're asymptomatic now, they could worsen. So syphilis is checked during pregnancy as well, at the booking appointments, and it's treated in the same way and managed in the same way. You look out for the same things as well. Frequency of transmission to the fetus is higher if they're in an early stage of syphilis. Remember, I said that the secondary stage of syphilis is you're at the most infective. But if you get syphilis at a later gestational age, then it can also increase your risk of the baby getting syphilis as well. So these are some of the congenital syphilis manifestations. The ones that kind of come up in questions, I think, are the Hutchinson's teeth and the saddle nose, and those are the things that I remember, and then it helps me remember the rest of them, because I know there's a lot of like congenital conditions to remember this year. But yeah, if you treat the mother, in most cases you've treated the child as well. Okay, so briefly going through viral hepatitis. So you would have mostly covered this last year, but there are 5 types of viral hepatitis. The way I remember them is I group A and E together, and B and D, and then C's in the middle by itself. So A and E, I think they're not as severe, and you normally get them via the same route. So you get them through fecal oral transmission, and E only becomes severe if the woman is pregnant, where it's associated with a 20% mortality. Other than that, A is very you don't need to manage it by a lot. It's very conservative in its management, and same with E usually. And they don't have serious complications either. A can present with jaundice, right upper quadrant pain, hepatomegaly, but this again dies down quite quickly. And then looking at B and D, so these I think are more serious. So they're transmitted through sexual contact and through mother and child as well. Same with D, and they have much more serious complications. They do need to be treated. Some of it can progress to chronic hepatitis and acute liver failure as well, and also some vasculitis as well. So you need to keep that in mind. So you can get B and D are related in two ways. Either you get B and D infection at the same time, which is like a co-infection, and that actually is associated with a lower, like a better prognosis. If you've got B and then you get D, that's known as a super infection, and that's associated with an even like a worse prognosis. And then hepatitis C is you can pass it on from mother to child, and it is the one where I think C stands for cirrhosis, C stands for chronic. I think it's the worst one, and it has many complications. So I'm just going to go through this SBA. So a nurse attends occupational health appointment to check if her Hep B vaccinations are up to date. Which of the following serology results is in keeping with the previous vaccination? So I think it might be easier to go through this and then come back to that question. Hepatitis, I always found this really confusing to understand, but I think the understanding what each one stands for and not overthinking is the best way to go about it. So hepatitis B surface antigen is positive in an infection. If somebody's infected, it's positive. I think if it's an acute disease, it can be present for 1 to 6 months, like within the 1 to 6 months window. And it can also be present, if it's present greater than 6 months, then you'd class it as a chronic infection. Because it's on the surface of the hepatitis B virus, it's kind of picked up first. That's how I think about it. So it's present in acute and chronic. In somebody who's naturally immune, they would have already fought off like the outer bit of the hepatitis B virus. So I don't think it's present. And also, if they're naturally immune to it, they've fought off hepatitis B, so it's not there anymore. When somebody becomes vaccinated, you actually vaccinate somebody with this hepatitis B surface antigen. But obviously, once you vaccinate them with this, the body starts to create antibodies against it, and therefore it wouldn't be present in the body anymore. So therefore, it's negative in somebody who's immune and in somebody who's vaccinated. Opposite to that, hepatitis B's are like negative in acute and chronic because they're like the antibody against hepatitis. That's how I think of it. And they're positive in somebody who's become naturally immune. So if they've contracted hepatitis B and then fought off against it, they would have the antibody to fight the surface antigen. And somebody who's become vaccinated against it, they would also have the antibody to fight off the surface antigen because that's what the antigen that they were given in their vaccination. And then you have hepatitis B core. So this is like the inner part of the hepatitis B virus. And this is positive in acute and chronic, but it's associated with different antibodies. So in an acute infection, you would have IgM antibodies, and in a chronic infection, you'd have IgG antibodies. It's also positive for somebody who's been naturally immune to hepatitis B because they would have been exposed to all the layers of hepatitis B. So they would have had to fight off the core antigen as well. So therefore, they also develop anti-HBC, and they're positive for that. When somebody's vaccinated, remember, they don't get that antigen, they don't get the core antigen, they just get the surface antigen, therefore they'll be negative against it. And another thing to look out for is HBe antigen. So that is like, I don't know why it's not even the same letter, but I just think E for infectivity. And it's basically released when the core antigen is broken down. So it's like another layer of the antigens, and the more there is, the more it means that the core antigen is being broken down, the higher the infectivity of the person with hepatitis B. So now moving on to this question, they have just been vaccinated against it. So they would be negative, sorry, for their surface antigen. So that rules out D as an answer. Then they would be positive for the anti-HBs because they have formed antibodies against the surface antigen. So that rules out, that leaves A and C. And then finally, they've never been exposed to the core antigen for hepatitis B. Therefore, they'd be negative against it, leaving C as your answer. So just looking quickly through serology for hepatitis C. So hepatitis C antibody, if you're negative for that, that means that you have no evidence of an infection within the 3 to 6 month window. You could have had an infection before, but you're not currently, or not in recent times. If you're positive for hepatitis C antibody, you'd want to check the hepatitis C antigen to see how recent your infection was. And if you then are negative for the antigen, that means that there's no evidence of an infection within the past 2 to 4 weeks. So if you are somebody who falls in this category, like no evidence of infection within the past 2 to 4 weeks, it means that you probably contracted HIV sometime, hepatitis B, not HIV, sometime between the 3 to 6 month period and the 2 to 4 week period. And then if you're positive for the antigen, that means you currently have the infection. So for hepatitis B, vaccinations are offered to everybody gets them. So children at 2, 3, and 4 months get them as normally part of their immunization schedules. Health workers, so we would have received them as part of occupational health as well. People who use intravenous drugs, sex workers, if close family contacts as well. People regularly receiving blood transfusions, so think like hemophiliacs, or and then people with CKD who require renal replacement therapy. And in about 10% of the population, they don't respond to the hepatitis B vaccination. And there's certain risk factors. If you could be one of those people that don't respond to it. Therefore, this group needs to be followed up 1 to 4 months after immunization to see if it's worked. And then hepatitis A, there's also a vaccination for it. It's there's an initial dose and then a booster given after, and it's kind of similar to who gets the hepatitis B vaccination, but more for people who get like blood transfusions, men who have sex with men, people who are from traveling to certain areas as well. So more thinking about how you can get Hep A. And then Hep B in pregnancy. So it's part of the screening along with syphilis, part of the booking visits. And so if the you'd give the baby a complete course of the vaccination hepatitis B immunoglobulin if their mother has a chronic hepatitis B infection, or if the baby is born to a mother who's had an acute hepatitis B during pregnancy. So those are the two scenarios where the baby would receive the vaccination and the hepatitis B immunoglobulin, and hepatitis B cannot be transmitted through breastfeeding. Okay, so just quickly speaking about this, because Mycoplasma genitalium presents very similarly to chlamydia and gonorrhea, but the most important feature about it is the fact that it's a non-gonococcal urethritis for men, and A lot of the times, however, it doesn't actually have any symptoms. So this is why doing the NAT is really important, because if it's negative for chlamydia, and you ruled out gonorrhea, then you could be thinking, oh, does this person have this? Because the way you treat it is with moxifloxacin, which is a different drug to what you'd give for chlamydia and gonorrhea. I don't even know if there's anyone left on the call. Okay, if you could fill out the feedback, that'd be great. But I just move on to HIV. Okay, so HIV is a human immunodeficiency virus. It is basically, it gets into the body through sexually transmitted, so it can be sexually transmitted and also from mother to child. And then it progresses, because once it comes inside the body, it manages to make its way into the like the structure of CD4 cells, like which are T cells, and it manages to integrate itself into the DNA of T cells. And it does this so that every time the T cell decides to replicate and produce more T cells to fight off infections, it also produces more HIV virus, and that can go on to basically eventually cause suppression of T cells, and it reduces the number of them over time if it hasn't been picked up. There are also two types of HIV, HIV-1 and HIV-2. HIV-1 is by far the most common type, and HIV-2 is a lot less common and only in like some areas of Africa. So normally you get the primary infection here, and then after you have like a seroconversion phase about 3 to 12 weeks after the infection. And this is symptomatic in about 60 to 80% of people. So in some people, they may not realize that they've even contracted HIV. But again, it presents very generally, like with glandular fever, style symptoms, so a sore throat, lymphadenopathy, malaise. Some people get a rash, and in very, very rare cases, they may have meningoencephalitis. But during this phase, about 3 to 12 weeks after the initial infection, they're very infectious, but they may not know it, which is why HIV spreads quite quickly and why clinicians are very worried about it as well. And then you enter something called an asymptomatic phase. And that's basically when the body kind of realizes, oh, we have a virus in us, we need to fight it. So the CD4 count recovers slowly, as you can see in this graph. But then after a while, the rate of HIV progresses even more, and the CD4 count slowly chips away, like I'm talking like within years, like 10 years, 20 years sometimes. And meanwhile, the viral load of HIV slowly increases to a point where if it's not picked up and if it's not treated, you get something called advanced HIV, which is when the CD4 count drops below 200 and you're at risk of opportunistic infections that you wouldn't have normally got before, and even certain malignancies. So HIV testing should be offered to anybody who is at higher risk of exposure. So this is people who have groups like men who have sex with men and their respective female partners, sexual partners, Black Africans, people who inject drugs, sex workers, prisoners, trans women, people who come from countries with high HIV seroprevalence and their partners. So never forget the partners when it comes to like STIs and gum in general. Always think about that. And also people who are attending health services, so people who work in sexual clinics and also the people that attend them, people that have conditions like TB, hepatitis, and lymphoma, which can affect your immune system anyway, or can be at higher risk of getting HIV. And also, you may be thinking, oh, if somebody presents with kind of vague symptoms, their sexual history and their lifestyle has certain red flags, you may be thinking, oh, it could be worth testing this person for HIV as well. So that's when you'd consider it. And obviously, if somebody's come forward saying one of their sexual partners has been diagnosed with HIV, then you'd obviously want to test them as well. So the structure that UCL and in particular Jonathan Cartilage love using is REBA. So this is the structure I think you should use in OSCEs when you're trying to counsel somebody for an HIV test, because there's so much stigma around HIV. It's important to do it right, because it could affect their compliance with their potential HIV medication in the future. So you'd first want to say the reason for testing. So is it something that the patient has requested? Is it something that you as a clinician have picked up, which is like a red flag to you? Is it something that they could be at risk of? So explain that clearly. And then you'd want to ask if they've ever been tested for it before. You could ask this as part of their past medical history when you're doing like a sexual history, or you could leave it up to this point. And then you'd want to talk about the exposures in the particular window period, so that they could have contracted HIV. So you want to ask in depth about the sexual exposures they could have had, or the needle sharing exposures that they've had. And that section should really help you confirm that you want to do the test for HIV. Then you'd go on to explaining the benefits of testing and the basics of how you're going to be doing it. So nowadays, most likely you just need to do a blood test for HIV. Point of care tests are things that are done not very commonly now, because that you can just do it for a blood test and it's better. So there's not much of an explanation, but it's always good to explain how long it will take for patients to get their results, because there's obviously a lot of anxiety about this, and to reinforce the idea of safe sex practices until they get their results, because they could be very infective. And then the last bit, which is very important, is agreement. So you need to obtain verbal agreement that they're happy to do the HIV test. And then if you look at this question, which is a 20-year-old man presenting to gum clinic with after having unprotected sex with another man, he's worried that he may have caught HIV. What is the most appropriate diagnostic test to provide an accurate diagnosis? So like I said, the antigen antibody test, which is now just a blood test, is used for diagnosis and screening, and it's the best test. So it's a combination test, and it involves looking for the HIV P24 antigen and also the HIV antibody. And some centers may also add like HIV, like viral load, basically, if they think HIV is quite likely at the time, but you don't have to. So when you're looking at the antibody, you'd use ELISA to pick it up, and then Western blot. And most antibodies for HIV develop at 4 to 6 weeks post, the antigen entering the body, but some take up to, like 3 months. But by 3 months, 99% of the antibodies would have been developed. So it may not be positive in early infection, the anti-HIV antibody bit. But the P24 antigen, that would be positive as soon as viral RNA levels rise, which is usually from 1 to 3 to 4 weeks after infection. And if the combined test comes back positive, you'd want to repeat it to confirm it, because obviously this is like a life-changing diagnosis in a way. They're going to have to be taking medication for the rest of their life and take certain precautions as well. So it's really important to help make sure that you've got it right. So yeah, if a test comes back positive, combined test 4 weeks after exposure, you would want to repeat to confirm. If it comes back negative, you'd want to repeat the test at 12 weeks. And the reason for that is because, like I said here, the 99% by 3 months. So you're waiting for that 3-month mark to make sure that you haven't missed anything. So going on to PrEP and PEP, I think that this is quite I found it quite confusing. But there's a really good Geeky Medics station on it that talks about PrEP, and I think that explained it so well. But essentially, PrEP can be offered to men who have sex with men, trans women who are engaging in condomless anal sex, HIV negative partners who are in same-sex relationship with an HIV positive partner whose viral load is not suppressed, and other people at high risk. So in the UK, the drug used is Truvada, which is a combination of two drugs, basically two anti-ARTs, basically. And you'd want to do some investigations before. So you'd obviously want to check if they have HIV before you do give them PrEP. And you'd also want to look at user needs because Truvada can affect that. And then when they're taking PrEP, like they could be taking it for a period of time as well. So you'd want to make sure that you promote STI and HIV testing every 3 months to make sure that, you know, they haven't contracted it regardless of taking PrEP. So you can take many types of PrEP. There are 4. The one that's most confusing is the event-based PrEP. So this, you need to communicate with the patient that they must know when they are going to be needing the PrEP. So PrEP is essentially pre-exposure prophylaxis. So it's when they know that they're going to be, you know, not using condoms or engaging in high-risk HIV activities like anal sex, and they want to protect themselves from contracting HIV during this time. So if they have a specific time and date in mind of when they're going to be needing this PrEP, then you'd want to give them 2 pills, 2 to 24 hours before they have sex, and then 1 pill 24 hours after they have sex, and then another pill 24 hours after that. So, and then they continue to take a pill every 24 hours until they're 2 days that they're sex-free. And that is event-based PrEP. You can also do the 4 pills per week kind of method, which is where they take a pill on a Tuesday, Thursday, Saturday, Sunday. Both of these PrEPs have only been trialed and tested for anal sex. They don't necessarily work for vaginal sex. The things that do work for vaginal sex and anal sex is daily PrEP. So when you take 1 tablet of Truvada every single day, or holiday PrEP, which is where you take 7 days of a tablet, all of those 7 days, and then when you're on holiday, you should take a minimum of 7 days of tablets, or more if you're on holiday for longer. And then after you come back from holiday, you take 7 days of another tablet. So daily PrEP and holiday PrEP have been trialed and tested for anal and vaginal sex. Event-based PrEP and the 4 pills per week PrEP have only been trialed and tested for anal sex. The best way to remember holiday sex is 7, 7+, and then 7. So the time that they're on holiday, they should take it every single day, and before and after, you're kind of sandwiching it in between with 7 days of PrEP. Post-exposure prophylaxis, like the name says, is you've been exposed to something, somebody has had a contact with someone who has become HIV positive, and they're worried that they've now contracted this. So they are coming to, you know, a sexual health clinic worried, and you can give PrEP in certain scenarios. So if they have, it should be routinely offered if they are receiving anal sex with a partner of an unknown HIV status, or the partner's HIV positive with an unknown viral load. If they're receiving vaginal sex of someone who's HIV positive and their viral load is not known. And if they also have an occupational risk from someone who's HIV positive and their viral load is unknown. And then people who inject drugs, again, after sharing equipment with someone who is HIV positive with an unknown viral load. So the key here is they should routinely be offered it if they're you know, receiving sexual activity from somebody who has an HIV status, or they have an HIV positive status, but the viral load is unknown. And you should consider it in inserted vaginal sex with somebody, you know, the person receiving it could be HIV positive with an unknown viral load. Then, and also the same goes for anal sex as well. So if somebody is performing inserted vaginal or anal sex with a partner who they don't know the HIV status of, then you should consider giving PEP in those scenarios. It's not recommended for like human bites, sharps, injuries, or inserted vaginal sex with a person of unknown HIV status. So if somebody is from an from a high-risk HIV group, but the person has performed unprotected vaginal sex with them, then that's not a good enough, that's not like it's not a recommended reason to give them PEP, basically. So PEP can be started within 72 hours. That's the magic number to remember, ideally within the first 24 hours. It consists of 3 drugs and 2 from a different classes. So, and it's given for 28 days. So the first one is your Truvada, which is also given for PrEP. And then on top of that, you want to give Raltegravir, which is a different type of drug, which we'll cover in the next slide, I think. You'd want to do baseline testing because they're taking these drugs for 28 days as well. You'd also want to check if they have HIV already. You'd want to check some of the other things that can, complicate this, which is like Hep B and Hep C. And you'd follow up with an HIV test 45 days after the course has been completed because of the way, the incubation period for HIV. Okay, so a 26-year-old man presents to GUM to discuss the results of his HIV test, which are positive. What is the most appropriate management? So the whole point of this is that they need to start ART like immediately. As soon as they become positive, they should be consented to start ART. So ART, there's many different types. This is like a table with all the different types. I don't think it's worth learning the different types, but it's worth knowing the names, like the protease inhibitors and the NRTs, and the slight differences between them, because NRTs are really important. They are the reverse transcriptase inhibitors. So they are the things that stop the viral RNA of HIV kind of getting into a state where it's ready to integrate into the host DNA. So that step is really important. And then the protease inhibitors kind of stop the HIV leaving as well. But you don't really need to know the rest. I think that the NRTs are the most important. Now, moving on to opportunistic infections. The next few slides cover opportunistic infections with great detail. I think I'm just going to speak on the ones that come up in questions quite a bit and I think are quite important. So also, the best way to kind of think about opportunistic infections is thinking about the CD4 count and thinking about what infections occur with this CD4 count. And that way you can categorize them instead of it just being like a jumble. So PCP is the most common opportunistic infection in AIDS. It is like a chest infection with shortness of breath, dry cough, fever. There's very few chest signs. And it has a very common complication of pneumothorax. It can also have, manifestations outside the lung, like hepatosplenomegaly. It can have choroid lesions and lymphadenopathy. The chest X-ray would show bilateral interstitial pulmonary infiltrates. Most importantly for PCP, and the way I remember it, is that it has exercise-induced desaturations. That's when the oxygen saturations drop as soon as there's some form of exercise or like walking for a prolonged period of time. Staining also shows, with silver stain shows cysts, and it's treated with cotrimoxazole, and in severe cases, IV pentamidine. So because this is such a common infection during AIDS, anybody with a CD4 count less than 200, which kind of qualifies for AIDS, should receive prophylaxis for PCP. Then this aspergillosis, so we know that fungal infections love to thrive when there's not a lot of immune response happening. So this is aspergillosis is one of the fungal infections you can get. Mycobacterium avium complex. To be fair, I think the key thing to remember for it is it has very general symptoms, but the CD4 count is extremely low. It's less than 50. So it is, the patient has must have a very high viral load if they're presenting with this. Then other opportunistic infections, again, other fungal infections. Then you have cryptosporidius. So this actually occurs in healthy patients and it's quite self-limiting. There's not much going on. But if somebody has HIV, it can be worse. And the reason why is the HIV ends up affecting like the whole of the gastromucosa, which is why it can cause sclerosing cholangitis and pancreatitis. The way it's picked up is using a modified Ziehl-Neelsen stain, and it will show red cysts. As with any opportunistic infection, if that's their first presentation and they don't know that they have HIV, they should be started on ART to help resolve the infection. And resolving and giving them ART should help them give the T cells they need to fight off the Cryptosporidius. Not much else is given directly for it. Then cerebral toxoplasmosis is the most common like cerebral manifestation of HIV. So I think 50% of cerebral lesions are down to toxoplasmosis. And it can have very vague signs, like neurological signs like headache, confusion, drowsiness, sometimes even seizures. A CT shows single or multiple ring enhancing lesions. The key is ring enhancing. And sometimes, depending on how many there are, there can be a mass effect, so like midline shift. It's given those two drugs. Basically, with toxoplasmosis, it's really easily confused with some of the other cerebral manifestations, and I'll speak about how to differentiate that in a bit. And then you have something called PML. So this is basically widespread demyelination of the nervous system due to a JC virus. And it can cause like behavioral changes, speech and motor impairment, and an MRI is a better choice, because on CT this also shows single and multiple lesions, but these are non-enhancing as opposed to toxoplasmosis, and there is no mass effect. But the best way to pick up any kind of demyelination, like you can think about MS, for example, is an MRI. So that's what's used to pick it up. Other neurological kind of conditions are cryptococcal meningitis. So this is the most common fungal infection of the CNS. It can cause meningitis, but also can cause like space-occupying lesions. Again, presents very similarly to toxoplasmosis, headache, fever, malaise, nausea, vomiting, focal neurological deficit. If you do an LP, that might have high opening pressures, and it test positive with an India ink stain. A CT would show like cerebral edema. So it's given antifungals along with some other medication. I don't know how important it is to know the exact medication used to treat it. I don't know how often that came up. Another kind of condition associated with HIV is primary CNS lymphoma, and this is the one that's often like thought of together with toxoplasmosis. They're quite difficult to differentiate. Primary CNS lymphoma is associated with EBV. It has focal or non-focal signs like confusion, lethargy, memory loss, so aphasia, seizures. So the manifestations of primary CNS lymphoma are a bit more neurological as opposed to like the vague symptoms of toxoplasmosis. But and both of them have single or multiple homogeneous enhancing lesions. But the key here is that with primary CNS lymphoma, these are usually single homogeneous lesions. They can be multiple, but usually they're single. With toxoplasmosis, it's more multiple and they're not homogeneous. If they are difficult to differentiate, and sometimes another scan called a thallium SPECT scan is done, and with that scan, primary CNS lymphoma would be positive and toxoplasmosis would be negative. That's a good way to differentiate it in like hospital setting. In order to manage primary CNS lymphoma, you'd want to give steroids and chemotherapy, and depending on the size, you may want to do surgery to resect the affected part of the brain. So this something you can read in your own time. I didn't really come across it during my revision last year. Yeah. And then, so one of the more like popular opportunistic infections is Kaposi sarcoma. So this is a tumor of the vascular and lymphatic endothelium, and it's caused by human herpes virus 8. So it causes like purple papules on the skin and mucosal surface, so also inside as well. And then lesions can develop in the lungs, lymph nodes, and GI tract and cause mass like hemoptysis, for example. And it's a very end stage kind of diagnosis. and it can be extremely life-limiting. And then CMV retinitis, again, it's got a very low CD4 count, so less than 50. It's caused by one of the herpes viruses as well, but this time it affects like the retina. Therefore, it causes visual impairment and blurred vision. A fundoscopy shows a pizza retina with like retinal hemorrhages and necrosis. And then it's treated with IV gangcyclovir. You don't need to carry on the IV gangcyclovir like for a long time. Usually you discontinue it when the CD4 count is higher than 150. So this is just going through some of the conditions and pictures as well. So one of the last things I want to speak about is the immune reconstitution inflammatory response. So kind of like syphilis, when like Apte started, so when therapy started against the HIV, the immune system responds to one of the previously acquired infections with like a really big inflammatory response, and this often worsens symptoms. So it develops 1 week to a few months after starting ART, and clinical features depend on like what kind of pre-existing infection they had or the body was trying to respond to. So you'd want to treat the underlying infections, and you want to give steroids to kind of dampen the immune response that's going on as well. And then really quickly, something to know about TB is one of the other like conditions that can happen when somebody has HIV. It can also happen when somebody doesn't have HIV, but it can be very severe if they have both. And having HIV can mean that the TB doesn't just stay in the lungs, it can be like disseminated, it can progress to different parts of the body. One of those also being like neuro-TB. But neuro-TB is like the least common of like the neuro manifestations of opportunistic infections. And basically, I think that it's essentially treated the same. There are some like additions in terms of the treatment, but normally and hopefully if the patient's already started ART, then they should continue the antiretroviral therapy, and then the TB therapy should be modified according to it, because these are obviously very strong drugs and they can have many implications as well and interactions, so they'd be adjusted if needed. But the same basis of treating TB still applies even when in HIV. And then HIV in pregnancy, this is one of the OSCE stations last year for us. So HIV is a routine part of booking tests for all pregnant women, and you want to reduce vertical transmission from mother to child. And you can do that by the mother receiving antiretroviral therapy, and which usually can be carried on during the pregnancy as well. And then closer to the time, around 36 weeks, if the viral load of the mother is less than 50, then they can have a vaginal delivery. However, it's greater than 50, then they would need to have a C-section with like an antiretroviral infusion during the C-section, so it doesn't pass on to the baby. And then the baby would carry on having antiretroviral therapy depending on the mother's viral load as well. And all patients, HIV patients in the UK, should be advised not to breastfeed and to use formula feeding as well. So that's something to remember. And really quickly, the last thing, so clinicians with HIV, sometimes you do get questions on it. So you should be able to perform like exposure-prone procedures. HIV positive healthcare workers must see like an occupational health consultant and an HIV consultant, have like 2 viral load tests greater than 3 months apart, both less than 200, have 3 monthly viral load monitoring, and they need to be on like the occupational health monitoring register. And essentially they need to be compliant with taking their antiretroviral therapy, and they also need to be compliant with attending these appointments for checking their viral load, because if they refuse to do that, or they have a viral load that is greater than 1,000, then you may no longer be able to perform some of the things like the exposure-prone procedures, and it may affect your ability to be a clinician. So that's important to keep in mind. So the key thing with HIV, and probably the best thing I learned during the 5th year, was that U equals U. If somebody is undetectable with their viral load, that means that they cannot transmit it. So they can mostly carry on living a normal life. The most important thing with HIV is not stopping the antiretroviral therapy they're on, not changing it. And I don't know why it says don't start, but you need to discuss with a specialist to start it as well. So all of that's done by an HIV specialist. But yeah, hope that was good. Thank you. I'm gonna stop recording now.